So we're joined here with John Pearn. John, welcome to this session that we're going to be having. Now, your talk this afternoon, you're talking about burns.
Yes, indeed.
Yeah.
It's wonderful to be here. Well, my ancestors came from Taranaki, so it's wonderful to be here at this wonderful conference of the New Zealand Medical Association and the continuing medical education talks. One of the very important areas is, of course, burns management, which affects us all. It affects us as parents, as individuals, it affects us as ambulance officers, very much as general practitioners and then as specialists.
Cool, so it's quite a wide kind of spread topic, isn't it?
Yes, but it's universal, unfortunately. Everybody is at some risk to burns throughout their life.
Okay, and so what are you going to be covering in your talk this afternoon?
Well, I'm talking about the logical progression of prevention, firstly, then first aid management, which is very important indeed, then emergency care, and then long-term skilled hospital care, and then the aftermath.
Right, okay, so it's like kind of like the timeline
of
what happens.
The progression.
Yep, okay. Well, so let's start with prevention of burns.
Yes, well, all people who work in public health and preventive medicine know there are 4 portals of preventive medicine. There's public education, in other words, on the principle that if we're aware of a risk, we will be less likely to undertake risky behaviour. Secondly, better design, modifying equipment, machines, the environment to make it safer. And thirdly, legislation, which by law will make the environment safer, and in this particular context make burns less likely. And then of course there's a form of secondary prevention, that is better first aid and pre-hospital care. It won't stop the original injury, which has already happened, but it certainly can modify the outcome, the long-term outcome, very dramatically. So that's the preventive approach. With the first aid approach, we know from work in my own unit, we have a very big research laboratory to do with burns at the big children's hospital in Brisbane in Australia. And there we've established, and wonderful workers there have established, that if one gives 20 minutes of running water to a burn, it will reduce pain, of course, in the acute setting, but it also hastens healing and will promote reepithelialization. We don't know why running water particularly works, but there's some strange reflex in the skin, particularly in the post-burn situation, where if running water is applied, it does in fact make a significant difference to the outcome.
Maybe it's got something to do with vasoconstriction, I don't know.
Yes, we know, for example, if one is tickled, it's different from just a light touch. There's something different about the running of the water that alters obviously some sort of autonomic reflexes in the vessels, which are partly damaged by the burn, by the thermal injury, but also, of course, those that are surviving. There's something in their reaction to the running water.
And 20 minutes, you say?
Yes, 20 minutes. It's been quite established in our laboratory. We have a laboratory with experimental pigs, actually, and where they're given various burns under all sorts of controlled conditions. It's a very humane laboratory. The pigs suffer no pain whatsoever from the burn, and they're given analgesia, of course, as long as it's needed thereafter. They're much loved laboratory animals, but they do, in fact, work with that experimental model has led now to what's the international advocacy for pre-hospital care for burns management.
Okay, all right. And then the next part of your talk is you're talking about acute medical management after that. So is that when you're in the hospital setting? Or
yes, not only pain control is very important in the initial management of burns, because we know that if pain is better controlled, reepithelialization occurs more quickly. Again, we don't know why this happens, but it's quite definitely shown in our laboratory studies, and on humanitarian grounds, of course. Burns are a terrible injury, so pain control is very, very important. Resuscitation is important. The awareness of things that can happen in burns. For example, children or individuals caught in house fires. They may have relatively superficial burns, but we know the inhalation of hot gases can produce catastrophic effects within hours, with damage to the lung lining, and the type 2 pneumonocytes in the lung can be damaged, and that comes to the fore within hours of burning. So we look for singed nostril hairs and those sort of things in the management of burns in that acute emergency situation. the big message in all burns management is what we call staying ahead of the game. Staying all the time ahead, better first aid, ahead of the game, the 20 minutes of running water, better resuscitation techniques, better pain control, and then when we get into hospital, the estimation of the burnt area and resuscitation started immediately a child comes to hospital or an adult comes to hospital, so that we stay ahead of the game. The disasters that happen in burns happen particularly if one's always trying to catch up.
Yeah, so it's always about predicting what's going to happen.
Predicting what's going to happen is crucially important, and preventing infection is crucially important. So in the immediate hospital care of burns, of course, is cleaning the burn area. It's now realised, again from a lot of our own research, that debridement, cleaning of the wound, best done with what's called a VersiJet, high speed little water jet that the surgeon or the person in our patients will be doing to clean the wound and debride all the dead tissue away. And then an assessment of the type of burn, whether it's superficial, and we use a standard technique for grading burns, superficial burns like sunburn, which will heal without any scarring. And pain control and support is the mainstay, and prevention of infection is the mainstay of management of those. And there are partial thickness burns, in which the tissue is damaged or destroyed, but not down to the hair follicles and the sweat glands, which can regenerate themselves. So under those circumstances, the skin will re-epithelialize without the need of grafting, and with very little scarring, which is good. And then there's deep partial thickness burns, and then full thickness burns, which 100% need grafting.
And those are the worst ones, aren't they? The ones that you can't feel.
Yes, indeed. So those individuals are shocked terribly and need resuscitation and management. But the dead tissue is of course the nerves are destroyed there as well.
And part of predicting what's going to happen is knowing about planning long-term care as well.
Yes, indeed. Yes. The psychosocial care of the burn victim is crucially important, because life's never going to be quite the same for severe burn victims after that. There are all the problems of loss of function, the cosmetic changes which are dramatic, can be dramatic, particularly in burns around the face or in exposed parts of the body. And the management of that is a long-term affair. Individuals who've been badly burned or suffered severe thermal injury, of course, may require 10, 20, 30, 50 plastic surgical operations over the next 10, 20 years of their life, and that involvement in the management of that is just as important, of course, as the early first aid.
Lovely. Thank you so much for coming and sharing that with us today, John.
Great pleasure.
Wish you all the best for the talk this afternoon.
Thank you.
Cool, thanks.